When you look at the history of medical science, there is this, I guess, this expectation of a steady, parallel march of progress.
Right, like everything advances at the exact same pace.
Exactly. We just assume that if we're studying one half of the population, we are naturally studying the other half with, the same exact rigor.
Which is definitely not the case.
No, it's not. Because then you look at the timeline of sexual medicine and you hit this absolutely massive, staggering gap.
It's a huge blind spot.
It really is. Consider this, if you're listening. The male physiological sexual response, so specifically things like nocturnal penile tumescence, that was being quantified and measured by scientists as early as 1944.
Yeah, 1944.
But the first published objective physiological correlate of the female sexual response, that didn't happen until 1968.
Which just represents a remarkable delay. I mean, you're looking at more than 2 decades of near silence in the clinical literature regarding how the female body physically responds to sexual arousal.
Right.
At least, in terms of objective, quantifiable measurement.
And that is exactly what we are exploring on today's deep dive. We're welcoming you to a real unpacking of the fascinating, highly technical, and historically very delayed science of measuring the female sexual response.
It's quite a journey.
We are going to dig into the exact biological mechanisms of arousal and the incredibly ingenious and honestly, sometimes totally bizarre tools that engineers and doctors have built to try and capture it.
And to really understand why it took so long and why it remains such a complex field today, we kind of have to start with the fundamental biology.
Okay, lay it on us.
So at the core of female sexual function is this process called vasocongestion. Put simply, that's just localized blood flow.
Got it. Blood flow.
Right. And the great challenge for scientists, historically and even right now, has always been how to measure the invisible internal mechanics of the human body accurately.
Without, I imagine, disrupting the very process they're trying to observe.
Exactly. You don't want the measurement to ruin the experiment.
Okay, so let's slow down and start right there. Because before we can even begin to talk about the gadgets and the lasers and the probes they use, we need to understand the biological event they are actually attempting to record.
Right, the actual physiology.
Yeah, so if you are a listener trying to picture this, what is actually happening down there on a microscopic level when vasocongestion occurs?
Well, it begins with this brilliant cascade of events. So, during sexual arousal, blood surges to the vaginal mucosa.
Which is the lining, right?
Yes, the innermost lining of the vaginal walls. As this blood rapidly pools in the area, it creates just a tremendous amount of pressure in the capillary beds surrounding those walls.
Oh, okay. So it's like turning on a garden hose when the spray nozzle is closed shut. The water is rushing in, but it can't get out, so the pressure just builds and builds inside the line.
The mechanics are very similar to that, yeah.
Oh.
And this localized increase in hydraulic pressure, it forces a specific fluid, which is called a plasma transudate, to physically pass through the tiny spaces between the cells of the vaginal walls.
Wow, okay.
But the most fascinating part of this mechanism is the chemical shift that happens at the cellular level to actually allow this fluid to surface.
Wait, a chemical shift? I assumed it was just, blood pressure pushing liquid out, kind of like sweat.
No, it's much more dynamic than just a simple mechanical push.
Really?
Yeah. In an unaroused state, the vaginal fluid has a very specific baseline makeup. It contains high concentrations of potassium and low concentrations of sodium.
Okay. High potassium, low sodium.
But when that capillary pressure builds during arousal, a massive sodium transfer takes place. The plasma, pushing its way through, brings highly concentrated levels of both sodium and chloride into the space.
So the chemical signature of the entire environment just flips.
Completely. And the cells lining the vagina, they start rapidly absorbing this incoming sodium. But the thing is, they have a limited reabsorptive capacity.
Meaning they can only take in so much.
Exactly. Eventually they hit a wall, they get totally saturated, and they cannot take in a single additional molecule of sodium. And that prohibits the fluid from being reabsorbed back into the cells.
Okay, let me see if I have this right. So if you're listening to this and trying to visualize the cellular level, imagine a dry household sponge.
That's a good way to look at it.
Right. So you spill some soapy water on the counter, which represents our sodium here. You put the sponge down, and at first the sponge just drinks it all in.
Naturally.
But eventually, that sponge is totally saturated. It cannot hold another drop. If you keep pouring soapy water onto it, the fluid has absolutely nowhere to go, so it just starts pooling on the surface.
The cellular behavior mirrors that sponge almost perfectly.
Uh-huh.
Because those cells are saturated, small droplets of this plasma are forced completely through the tissue.
It's just pushed right out.
Right. They move to the surface of the vaginal wall, initially appearing as just tiny droplets, and then they coalesce to form a continuous moist barrier. And this lubricative film is biologically crucial because it protects the tissues from tearing during penetration. And as a direct byproduct of this entire sodium transfer, the overall pH of the vaginal canal actually increases.
So wait, is it accurate to think of vaginal lubrication not as a glandular secretion at all? Like it's not like sweat or saliva?
Well, there are some minor glandular secretions involved, sure, such as from the Bartholin's glands, but the primary source of this lubrication is indeed that transudate originating from the vascular bed.
So it's essentially filtered blood plasma driven to the surface by sheer hydraulic pressure?
It is passively transported through those cellular channels by exactly that, the sheer hydraulic pressure of pooling blood.
That is wild. It's entirely pressure-driven. So if arousal is essentially this internal hydraulic pressure system, how do scientists actually look inside the body to measure it?
That is the tricky part.
I mean, you can't exactly wrap a standard blood pressure cuff around an internal organ.
You really can't. And that limitation leads us to the most common and honestly arguably the most debated tool in the entire field, the vaginal photoplethysmograph.
Okay, photoplethysmograph is a mouthful. What does it actually look like in practice?
Its physical design is surprisingly simple. It's a tampon-sized acrylic device that a subject can easily insert themselves in a private setting.
So they don't need a doctor in the room for that part.
No, which is a big benefit. And encased inside this clear acrylic shell is a light-emitting diode, an LED, alongside a small photodetector.
So it's basically a little glowing tampon. But how does a light bulb measure blood pressure or blood flow?
It relies on the principle of backscattered light. So the LED constantly illuminates the microcirculation of the surrounding vaginal tissue.
Okay.
And when human tissue becomes heavily engorged with blood, it becomes significantly less transparent.
I see.
So the device measures how much of that LED light reflects, or backscatters, back into the photodetector. The intensity of the light bouncing back shifts depending on the volume of blood pooling in those capillary beds.
Oh, I think I get the mechanism. So if you're sitting in a pitch black room and you press a strong flashlight directly against the palm of your hand, you see that bright red glow because the light is passing through the blood in your hand.
The concept is absolutely identical.
But wait, if I'm just looking at the red glow of my hand, I can tell blood is in there, sure, but I certainly couldn't tell you how fast that blood is moving or what the actual volume is.
And you've hit on the major limitation. The device doesn't provide speed, and it doesn't offer anatomical detail.
So what does it actually give you?
It translates that reflected light into two distinct electrical signals. First, there's the DC signal, which stands for direct current. This signal measures vaginal blood volume.
Okay.
So it's tracking the slow, gradual pooling of blood in the tissues over a long period.
Sort of measuring the rising tide of that hydraulic pressure.
Exactly. And the second is the AC signal, or alternating current. This measures vaginal pulse amplitude.
Pulse amplitude.
Yeah, because blood pressure spikes slightly with every single heartbeat, right? So the AC signal catches that rapid, microscopic alternating pulse in the tissue as fresh waves of blood hit the capillary bed.
Okay, here is where I start to see a problem, though.
Uh-oh, what's that?
Well, if this thing is just measuring light bouncing off tissue, what happens if the person moves? If you just shift your hips, wouldn't the device move, the light would hit a totally different spot, and the data would just spike?
You nailed it. Movement artifacts are a massive hurdle for this device. Any significant physical movement by the subject creates these chaotic readings that completely corrupt the data.
Wow.
This means researchers cannot reliably use the device during actual physical stimulation or orgasm because those are highly kinetic events.
That is so counterintuitive. You're studying physical arousal, but you can't allow the subject to physically move.
It's very frustrating for researchers, yes.
And on top of that, these units, like the light bouncing back, they aren't absolute measurements, right? I mean, it's not giving you a volume in milliliters. It's just a relative more light or less light.
Right. The data is entirely relative. It shows a baseline and a change from that baseline. But it doesn't give a clinician an absolute unit of measurement that they can compare perfectly across different patients.
Plus, Reading through the sources for this deep dive, there seems to be this recurring phenomenon where the physical data from this device completely contradicts the subject's feeling of arousal.
Oh, the concordance issue,
Right.
yes.
The machine says the tissue is engorged, but the person reports feeling absolutely nothing. So if it just gives relative signals, can't be used during physical movement, and sometimes completely contradicts the subject's own brain, how on earth did this become the gold standard?
Honestly, necessity drove its adoption. Despite all the flaws you just mentioned, it allows for continuous moment-to-moment measurement over a long duration in a way that is totally non-invasive and painless.
I guess that's true. They can just insert it and be alone.
Exactly. The subject can insert it alone in a private room. But those frustrations you just listed, specifically the desperate need for absolute quantifiable data that isn't ruined by a slight movement, that pushed researchers to look toward more advanced clinical technology.
Which brings us to the heavy machinery. If you want hard, absolute numbers, you have to break out the ultrasound.
Specifically, duplex Doppler ultrasound.
Okay.
This completely bypasses the limitations of arbitrary light reflection, because instead of relative changes in backscatter, Doppler ultrasound provides researchers and clinicians with real-time, absolute blood velocity.
Wow.
It actually measures the speed of the blood flowing through the vessels in centimeters per second.
Okay, so we are finally getting actual speed limits. How does the Doppler single out the blood flow?
It isolates two specific metrics. There is peak systolic velocity, which is the maximum speed of the blood during the heart's contraction.
Right.
And then there's end diastolic velocity, which is the speed of the blood when the heart rests between beats. Capturing this data requires a highly specialized, patented ultrasound measurement probe. And from what the research shows, operating this probe requires an intense level of precision.
Oh, the operational parameters are incredibly exacting. The clinician must insert the probe into the vagina to a specific depth of exactly 6 centimeters.
Wait, why specifically 6 centimeters? What happens if they go to 7 or 8?
Depth dictates the target. At exactly 6 centimeters, the vaginal arteries are perfectly accessible for measurement.
Okay.
But if the clinician inserts the probe to deeply reaching, say, 11 centimeters, the signal will completely overshoot the vaginal artery, and it'll mistakenly measure blood flow in the uterine artery instead.
Oh, wow.
And capturing the wrong artery completely invalidates the data if you're trying to study vaginal arousal.
Wow. Okay, so depth is crucial. But I also saw that the angle of the probe is just as heavily engineered. Yes. The probe's physical housing is engineered to force the internal ultrasound transducer to sit at precisely a 60-degree angle of incidence relative to the blood vessel.
Okay, why an angle at all? I mean, why wouldn't a doctor just point the ultrasound straight at the side of the artery to get the clearest picture?
Because sound waves require motion relative to the receiver to calculate speed. If you point an ultrasound beam directly perpendicular to a blood vessel, so a 90-degree angle, the blood is just moving across the beam, not toward it or away from it. So the machine registers a Doppler shift of 0.
Oh, I see it now. Think about a police officer using a radar gun on the side of a highway.
Perfect analogy.
If the cop stands directly on the side of the road and points the gun completely perpendicular to the side of your car as you pass by, the gun registers your speed as 0. The radar waves need your car to be moving slightly toward the gun or slightly away from it to actually calculate how fast you're going.
The physics governing the police radar and the ultrasound probe are identical. So the 60-degree angle is the clinical sweet spot. It provides enough of an angle to capture that Doppler shift while also minimizing the amount of tissue the sound waves have to travel through.
That makes total sense.
And to measure the blood flow on both sides of the body, the clinician simply rotates the probe to the 9 o'clock position for the right vaginal artery and the 3 o'clock position for the left.
I also read something about a standoff material being used on the tip of the probe.
Yes, the transducer inside the probe has a specific focal distance. That's a predetermined point in space where its acoustic beam is the narrowest and most accurate.
Okay.
But because human anatomy varies, you can't always just press the hard plastic of the probe directly against a tissue and hope the focal point lands perfectly on the artery.
Right, everyone's different.
Exactly. So the acoustic standoff material is a layer that mimics the acoustic properties of human tissue. It basically acts as a physical spacer. It allows the transducer to sit back slightly while maintaining a perfect sound wave connection, ensuring the focal point lands exactly where it needs to.
Okay, from an engineering perspective, this is undeniably brilliant. It solves the absolute data problem, it gets rid of the movement artifacts from the light sensor, but I have a massive pushback here.
Let's hear it.
We are talking about sexual arousal. I want you, the listener, to really put yourself in the clinical environment we just described.
It's intense.
It is. Imagine trying to experience physiological arousal while a medical professional stands over you, holding a gel-covered ultrasound probe exactly 6 centimeters deep inside you, monitoring a glowing screen, and rotating the device from 9 o'clock to 3 o'clock.
Yeah, it's not exactly romantic.
Does that environment actually reflect a natural state for a human being? Doesn't the intense clinical precision completely kill the very physiological response it's trying to measure?
You've highlighted the greatest paradox in sexual medicine. It's often referred to in sexology as the observer effect.
The observer effect.
Right. Duplex Doppler ultrasound provides spectacular, undeniable data for diagnosing structural or vascular issues. Like, if a patient has atherosclerosis preventing blood flow to the clitoris or vagina, this machine will absolutely find it.
Sure, it's great for pathology.
But the environment is highly sterile, deeply clinical, and inherently anxiety-inducing. Separating a subject's true physiological capacity for arousal from the psychological inhibition caused by the testing method itself is incredibly difficult.
So we built a machine that can measure blood flow perfectly, but the act of using the machine causes the brain to hit the brakes and stop the blood from flowing in the first place.
That is exactly the issue. And the frustration surrounding that exact paradox is why researchers have spent decades searching for alternative metrics. Because the ultrasound requires a clinician actively holding a probe, scientists began looking for ways to measure the downstream effects of that blood flow without having to look directly at the arteries themselves.
And this is where the history of this science takes a turn for the truly wild. Reading through the historical methods they attempted for this deep dive, some of these sound like something out of a Cold War sci-fi movie.
Oh, the historical literature is just filled with extreme methodological attempts. One of the most aggressive was the xenon-133 wash-up technique that they utilized around 1980.
Xenon-133, that is a radioactive isotope, right?
It is a radioactive gas, yes. Researchers literally injected this radioactive tracer directly into the vaginal epithelium of their subjects.
Wait, they injected radioactive gas?
Yes. They then placed a scintillation detector nearby to measure the gamma emissions as the pooling blood washed the radioactive tracer away from the injection site.
That is mind-blowing. I cannot imagine a scenario where getting injected with radioactive isotopes into highly sensitive tissue puts anyone in the mood.
No, it was certainly extreme. Though, I will say, it did successfully prove that blood flow increased threefold during self-stimulation.
Well, I guess that's something.
But obviously, injecting radioactive material is highly invasive, fraught with ethical and safety concerns, and completely non-viable for widespread clinical use.
Yeah, I would hope so.
So researchers pivoted to measuring other secondary effects of blood flow, like heat. As blood rushes to the genitals, the ambient tissue temperature naturally rises.
Okay, that sounds much more reasonable, just measuring heat with thermometers. Did that work better?
Well, they developed labial thermistor clips. These were tiny thermal electrodes designed to clip gently onto the labia to measure temperature changes.
Okay.
They also experimented with thermography, which is essentially using infrared cameras to capture a heat map of the pelvic region.
That seems like a massive improvement over radioactivity, honestly.
Thermals provided an absolute scale of measurement, in degrees, and the sensors were less prone to the movement artifacts that plagued the photoplethysmograph. However, they shared a major vulnerability: extreme sensitivity to ambient room temperature. If the laboratory was just a bit chilly, or the building's air conditioning kicked on mid-experiment, it completely skewed the data.
Oh, of course. So heat was out because you couldn't control the weather in the lab. What else did they try?
Pressure compliance. They attempted to measure the physical expansion and volume of the vaginal canal using what are called Schuster balloons.
Balloons?
Yes. Researchers would insert a specialized balloon and inflate it with up to 300 cubic centimeters of air to measure changes in intraluminal pressure as the vaginal walls relaxed and expanded during arousal.
Wait, 300 cubic centimeters of air? That sounds incredibly uncomfortable.
It was. The historical protocols often dictated that the test would literally continue until the patient actively noted discomfort. The invasive nature of inflating a large balloon often completely disrupted the very arousal process they were attempting to study.
If you're listening to this, just think about the sheer amount of money, time, and engineering that went into these attempts. We have radioactive injections, highly calibrated infrared heat maps, and 300cc balloons. It really feels like they were wildly over-engineering the problem of just trying to measure localized blood flow.
And modern researchers have largely come to the exact same conclusion. Recently, there has been a significant shift away from these highly complex, invasive, and intimidating methods.
Which makes sense.
Instead of trying to measure the internal blood flow via Doppler or the ambient heat via thermistor, they're going back to the very first biological mechanism we discussed today, the plasma transudate, the lubrication itself.
Ah, the soapy water pooling on the surface of the sponge.
Exactly. Historically, scientists tried to measure this transudate by physically weighing tampons before and after arousal, which was messy, totally inaccurate, and prone to evaporation.
Yeah, that sounds pretty flawed.
But lately, researchers are finding incredible clinical success using something almost laughably simple: litmus strips and Schirmer tear test strips.
Wait, litmus paper. Like the little strips of paper you use to test the pH of a swimming pool or in middle school chemistry class?
The exact same fundamental concept. Clinicians place these simple, sterile paper strips right against the vaginal wall. The Schirmer strips, which were actually originally designed by optometrists to measure eye moisture, they objectively measure the exact volume of fluid being produced based on how far the moisture travels up the paper.
That's so smart.
And the litmus strips instantly measure the exact pH changes we talked about at the beginning of the show, capturing that exact moment when the sodium floods in and the pH in the environment rises.
Oh, the irony of that is just too good. I mean, after decades of inventing complex lasers, engineering perfectly angled Doppler probes, injecting radioactive isotopes, and inflating giant compliance balloons, modern researchers are realizing that a tiny strip of paper that changes color might be one of the safest, most objective, and least invasive ways to assess healthy function in a laboratory setting.
It really represents a beautiful full-circle moment for the scientific method. The paper strips circumvent the movement artifacts of the photoplethysmograph. They entirely remove the clinical intimidation of the ultrasound probe, and they safely and directly measure the physiological end result of vasocongestion.
So to bring this all together, the journey of female sexual medicine has been incredibly long and full of wild detours. From the 1830s, when a French doctor named Jacquemin simply noticed the bluish color changes in tissue during pregnancy, to the 1968 baseline discoveries, to today's high-tech array of 60-degree Doppler probes, and finally, a return to litmus paper.
It's quite a timeline. The underlying biology of plasma transudation and vasocongestion is beautifully complex. But as this history reveals, measuring it accurately remains a very delicate ongoing balance between achieving strict engineering precision and maintaining genuine human comfort.
So if you're listening and wondering why this complex history of gadgets actually matters to your life or the future of medicine, what is the ultimate takeaway here?
Well, understanding how we measure function is the only path to properly defining and treating dysfunction.
Right.
If medical science cannot accurately map the normal physiological response, clinicians simply cannot develop targeted, effective therapies for individuals suffering from vasculogenic impairment.
That makes total sense.
For a very long time, female sexual dysfunction was treated with guesswork or just dismissed entirely as a psychological issue. Tools like the Doppler ultrasound, by proving that structural blood flow issues exist in women, just as they do in men, validate those physical experiences and pave the way for real, localized medical treatments.
Okay, I want to leave you with one final thought to mull over. We've talked extensively today about the mechanics of the body, the pressure, the plasma, the blood velocity, but let's go back to that discrepancy we discovered with the photoplethysmograph.
The concordance issue.
Yes. If a highly calibrated machine proves that your blood vessels are engorged and your body is exhibiting 100% physiological arousal, but your brain reports that you don't feel aroused at all, where does true sexual function actually reside? Is it entirely in the blood vessels, purely in the mind, or somewhere in the mysterious unmapped neural bridge between the two?
That tension between the physical data and the lived experience raises a deeply important question, and perhaps it remains the greatest frontier in this entire field of science.
Definitely something to think about. Catch you on the next deep dive.